Any questions from the first half, what we covered? All right, sounds good. We're going to try to get through Unit 4 here as best we can. So we'll talk a little bit about adverse reactions. We'll talk a little bit about bioequivalency and bioavailability. So, all right, so we're talking about adverse reactions. Usually this is going to be considered being kind of like harmful or really kind of unpleasant sort of effect that may manifest from use of a drug. Again, usually this is going to be something that may warrant either a specific treatment or something like try to prevent the adverse reaction from occurring. It may mean you have to alter the dosage form or the regimen, how often or how much you're going to be giving, or in some cases maybe you just withdraw the product altogether, right? So if you have a kind of an intolerable adverse reaction, maybe something you don't want to give it anymore, right? Usually when we're looking at adverse reactions, we're going to have these 6 sort of categories. So it's good to be able to kind of identify what kind of issue you're dealing with when a patient manifests an adverse reaction. So they kind of use this A, B, C, D, E, F mnemonic. But basically the ones we're going to run into are going to be dose related, some that are non-dose related, dose and time related, which is more of a chronic issue. There's going to be time related, withdrawal, and then failure of therapy. Okay, so we'll talk about each of these individually in a second. So dose related, as you might imagine, is just related to the dose that we're giving, right? So again, this is pretty common, right? So again, this is usually related back to the pharmacologic action of the drug. So for instance, if I give you insulin, it's usually to do what? Lower your blood sugar. If I give too much insulin, hypoglycemia, right? So that makes sense based on the actual action of the drug. It's very predictable, typically pretty low mortality. Now, you can kill someone with insulin for sure, but typically you're going to hopefully be able to catch those sort of things, right? This includes a lot of side effects. They're also related to dose as well. So for instance, if I give you a little bit of insulin, you may have some weight gain, but if I give you a lot of insulin, you may have more weight gain associated with that, right? So we know those sort of things you're going to see with drugs. Mentioned sedation with antihistamines, right? So for instance, if I take a lot of Benadryl, I may be able to get very sedate. Some people may get very anxious, but we'll go with the kind of the more common thing you run into. However, some people use that for its intended effect, right? Some people use that to go to sleep, as the case may be. Other things, hypotension with calcium channel blockers, any kind of antihypertensive. Again, I use it to lower blood pressure. If I get too much, I get hypotension can develop. So non-dose related things are kind of more these bizarre sort of like idiosyncratic sort of reactions that occur. These are uncommon and typically are not related to the pharmacologic action of the drug itself. Because of that, it's usually unpredictable as to who's going to have an issue with it and may lead to things like higher mortality because it's hard to predict who's going to have an issue. People may have these reactions and we can't guarantee who it's going to be. Example would be something like an allergic reaction to penicillins. I can't look at a person and say, hey, are you likely to have an anaphylactic reaction? So because of that, we'll give it to plenty of people who don't have reactions, but then every once in a while you run into that one person, right? Another good one would be like malignant hyperthermia. So if you go work in surgery or in the ER, you realize there's certain drugs that you need to ask about patients. Do they have a history of anesthesia or bad reactions to anesthesia? And what kind of reaction was it? Because it could be this malignant hyperthermia. It's a genetic sort of polymorphism that manifests or that causes malignant hyperthermia, and again, it's hard to predict who might have that mutation. There's time and dose related issues. There's going to be chronic problems, relatively uncommon, but usually it's going to be related to the cumulative dose or the time that the patient's on the drug itself. So for instance, if you're looking at things like corticosteroids, so I'm giving you like prednisone or dexamethasone or methylprednisolone, anything like that, what you're going to find is that when I give those steroids, the adrenal glands, which normally produce a lot of your corticosteroids, what do? They stop producing because they're like, hey, I got enough drug around here already. I don't need to do any work, right? So if you have a patient who's on it for a long period of time, say like greater than a week, you need to make sure that you taper them off of those steroids because otherwise, if you withdraw that too quickly, guess what? You have adrenal suppression, you have adrenal hypoactivity, you're going to basically put them into an adrenal crisis, right? So again, you have to make sure you supplement that in order to kind of get them back because again, their glucose is going to go out of control, their blood pressure will go out of control. You have to be careful with that. So, as a general rule of thumb, if you're on say a steroid more than a week, we'll go ahead and taper you down off of that. Some people, they'll do it for a lesser period of time, but usually if it's less than a week, I don't have to worry about that. So if I have a patient who comes in for an asthma exacerbation, I give them a 5-day course of prednisone, I don't have to worry about tapering them off of that because the adrenal glands haven't had time to really stop production. However, if I have someone who's like, say, has rheumatoid arthritis and they're going to be on it for months and months and months and they want to come off of it, I have to taper that down very carefully. Otherwise, their adrenal glands are not going to have time to catch up and start production of cortisol, right?
Is that line like the mental dose back? It's not much of a problem?
Yeah, so that's why the Medrol dose pack is a thing. So again, it's one of those things where like you may take like 6 pills on day 1, and then 5, and then 4, and 3, and 2, and 1. That is already has a built-in taper to it. It's probably unnecessary for most cases, right? So again, I think older thinking was that you always have to taper off the steroids, but that's really not how we practice nowadays. But the Medrol dose pack's been around forever, so it still gets used pretty frequently. It's not wrong to do it. It's just probably not necessary, as the case may be. So there's going to be some time-related or delayed reactions that can occur. Again, pretty uncommon for the most part. Usually not going to be dose-related. And again, you're not going to find these issues developing until sometime after the drug use has already occurred here. So for example, if I have someone who has, say, bipolar disorder and they're taking valproic acid for this and then they get pregnant, right? Usually pregnancies take how long before you see any problems manifest? Probably 9 or 10 months afterwards, right? And so patients may have things like neural tube defects, right? So again, you can have these very significant neurologic issues that can develop these kids because of this teratogenesis. We'll talk more about that later on, probably in Pharm 1 or Pharm 2 when we talk about women's health stuff, issues, and we'll talk about teratogenesis. But anytime you hear of a drug causing a birth defect, that's called a teratogen, or teratogenesis has occurred, okay? Other things would be things like tardive dyskinesia, which you can see with some antipsychotics. So patients, especially on old school antipsychotics, they'd be on these drugs for years and years, and they would develop these kind of movement disorders as a result of that, and then we call that tardive dyskinesia. It's something that's not related to the dose of the drug necessarily, but just the time frame that they were on it, whether it be years and years and years or whatever happens to be. So, other adverse reactions you can see with withdrawal of certain medications, again, pretty uncommon, but they should occur as soon as levels of the drug get down to below a certain threshold where you start to manifest some of those symptoms. So, it depends on the half-life of the drug. So, for instance, you think about opioid addiction, right? The reason why a lot of people relapse when they're trying to get treatment for that is because they have withdrawal symptoms from their opioids. So, one of the things we'll actually do is try to give them a longer-acting drug to try to help them mitigate some of those withdrawal reactions. So, for instance, anyone know what you used to try to get people off of opioids? Methadone. Methadone is a very long half-life, like 50 some odd hour half-life, and so that's why you see like methadone clinics, right? So patients will go Monday through Friday, get their methadone. They've kind of started building up their dose, right? Because again, they're trying to get to a steady state level, and then when the clinics are closed on the weekend, they have a nice high level that they can kind of ride throughout the weekend that has a long half-life, so the level should go down pretty slowly to prevent withdrawal, and then when they open up on Mondays at a methadone clinic are kicking. Let me tell you what, everyone's there because their levels are starting to get low and they're trying to stave off that withdrawal, right? Because otherwise they can potentially relapse and start going back to heroin or whatever they like to use. So opioid withdrawal is a good one. Another one could be like a myocardial ischemia after a beta blocker. So remember we talked about with chronically blocking receptors, what do they like to do? Upregulate, downregulate? To upregulate because they've been kind of blocked for a long period of time. So you can see that patients who come off of their beta blockers very abruptly, they may, and especially if they were using it for things like previous MI or used to try to decrease that oxygen consumption of the heart, and you come off that very abruptly, they have all these receptors. Now all this epinephrine they're releasing can interact with that, and all of a sudden oxygen consumption is going to go up as heart rate goes up, contractility goes up, and guess what? Now you can induce another MI. Okay, so that's one thing we've seen occasionally. That would be another drug you want to taper off very slowly until you kind of get them back down to baseline. So you can have unexpected failure of therapy. So these can be pretty common depending on kind of the disease state you're dealing with. Sometimes can be dose related and oftentimes are related back to drug interactions. So for instance, I mentioned if you're taking a fluoroquinolone, say you develop a pneumonia and I put you on a course of Levaquin. Again, I would not recommend doing that most cases, but let's say we're doing that. And then I give you something like an antacid, so something like calcium carbonate or Tums. That calcium can bind up the fluoroquinolone, right? So again, that's a failure of therapy because I never absorbed it at that point. Or for instance, if I had, say, oral contraceptive, so like a estrogen progesterone product, and I have an enzyme inducer on board, right? We talked about those interactions, and if I induce an enzyme, what does that mean? I've increased the number of enzymes, I increased the activity of it. So again, if I'm metabolizing that estrogen more effectively, what happens to those estrogen levels? They're going to decrease. What happens to the estrogen levels decrease? Doesn't work, you can ovulate, and guess what? Now the patient can get pregnant, right? So this is one of those things, and especially you don't want to mess around with birth control because guess what? Now you got a lifelong side effect you have to deal with. It's a heck of a side effect, right? So you don't want to be responsible for that. So you gotta watch out for that. Side effects include sleeplessness, frustration, lack of money, all kinds of things. But you love them forever. They're just great. Anyway, so. Now, the nomenclature here can get a little fuzzy. You may hear side effects and adverse reactions kind of being used interchangeably. Typically, you think side effect as being a little bit more of a minor sort of reaction versus adverse reactions being much more severe. So we'll talk about some instances where this can be, looking at a side effect versus an adverse reaction, right? As I mentioned, side effects can be a good thing. So I talked about Latisse or bimatoprost causing, nice long lashes, even though it is originally used for glaucoma, right? So, the other thing with the Latisse, it can actually cause the iris to actually turn brown. So again, if you have nice blue eyes, then you have a risk-benefit analysis. Do I want to have nice long lashes, or do I want to have brown irises? Or do I want both? And again, it's one of those things where it can be irreversible sort of change. However, if you already have brown eyes, it's not really a big deal. So like my wife, she likes to use it because she already has brown eyes. Not going to be a problem there, right? Other cases, let's imagine we're at the drug Bactrim. It's an anti-infective. It's a combination of two drugs called sulfamethoxazole and trimethoprim. So looking at like an adverse reaction versus a side effect can be rash, urticaria. So especially in sun-sensitive areas, anyone know what you call that? Photosensitivity, right? So again, if you have issues like sunlight, that could be a side effect. You know, maybe you just have them stay out of the sun for a little while they're on that course of antibiotics, right? Maybe they don't want to go out anyway because they're feeling kind of crummy because they have an infection. Who knows? However, if they develop, severe skin blistering, the skin starting to slough off, called Stevens-Johnson syndrome, that is a severe life-threatening sort of reaction. That is something that you need to educate patients on, like what's a known side effect, how do you mitigate that, but what are the things you need to come back, either go to the ER or come back to see me to potentially have a different drug being administered, what constitutes stopping a drug altogether. These are things you want to educate patients on. So that way they know, like, a lot of times they'll be experiencing side effects, but they don't know that it's a side effect. They just think they're getting older. They just think they're having, problems. Oh, I'm just getting constipated because I'm getting old. That's probably not the case. It could be related back to the medication. So you have to be the one to educate them on that sort of thing, right?
The past one where it said that look for the adverse reactions. So the ones that you actually look for is the side effect, not the definitely.
So usually you'll find all of them kind of listed within the same sort of thing. And so typically when you're looking at a drug reference, if there's something like really, really severely, like may kill the patient or may cause some serious issues, those will oftentimes get sequestered as a black box warning. And those will usually be at the top of the monograph, and will say, hey, big black letters, hey, this is a bad reaction that can happen here. So those are certainly adverse reactions. You'll still, when you get down to, like, say, Lexicomp, you're looking at those will intersperse side effects along with those adverse reactions. And again, you may hear us use the term interchangeably, but I kind of want you to be able to identify, okay, if they're having like a little bit of rash, like maybe that's just a minor sort of issue. May not necessarily mean we need to change treatment altogether. However, if they have something like Stevens-Johnson's, you need to recognize that as being a really kind of life-threatening issue, right? And so when you're looking at kind of the most common things, you may see like, okay, well, like an opioid, like, I'm really worried about things like respiratory depression. But is that really a common adverse reaction you see with the opioids? With common dosing, you don't really see that. Maybe some sedation, maybe some constipation, some nausea, vomiting. Those are common things you run into, but we're so concerned about the respiratory depression. That's what's going to kill the patient. But that's the adverse reaction. The side effect of sedation, nausea, vomiting, we understand that. We know that's going to be something we see with those drugs. Not necessarily, so not necessarily going to be like a true blue, like an IgE mediated reaction. Sometimes you just have that kind of photosensitivity, you get that kind of that dermatitis that can develop. So it just depends on the drug, for sure. Other things. So again, looking at the drug Viagra or sildenafil, what do we use that for? Erectile dysfunction. I tell you guys that I give like little girls. Yeah, so we use it for things like pulmonary hypertension as well. So an adverse reaction could be something like a sudden loss of vision, right? So again, if you go blind while you're taking Viagra, guess what? Probably not a good thing, right? However, side effect, upset stomach. Okay, that's something I can tell. Maybe if you take some Zantac with that, maybe it can help to deal with some of the upset stomach. But adverse reaction going blind, that's something you want to be able to educate for, right? How about lisinopril, an ACE inhibitor? A side effect could just be that cough I mentioned, kind of that buildup of bradykinin causing that dry cough. However, if they manifest angioedema, they start to have this big giant tongue, they'll start to swell up, they lose their airway. That's severely life-threatening. That's something you need to get them in the ER immediately for.
So I have some of the angioedema.
Yeah.
Would actually work on that?
So actually, it's outside of our scope for this talk, but epi is not going to work as well for that because it's not really like an anaphylactic reaction like you're going to see with, say, like peanut exposure to someone who had an allergy to it before. Most people are still going to give epi, but the biggest thing is just to get the airway fixed. Steroids might have some role there, but most people are still going to get like the full anaphylactic sort of full court press, regardless, because it looks like it, and so you typically treat it like it is until proven otherwise.
Does that mean you don't use Viagra for you have specific, say, little girls?
Mm-hmm.
You cannot use it in boys?
Oh yeah, I can use it in little boys too. I just like to use that as an example because like you think like the main user of Viagra being like a middle-aged man. I use it for little girls too, right? So again, kind of everyone in between can potentially use it. Yeah. So yeah, there's no gender disqualifier for little boys getting it as well. We'll talk about Viagra later on. So it's not like every little boy who gets it is going to develop an erection. Like there's other. It's more complicated than that. We'll get to that later on. Anywho. So when looking at trying to prevent some of these adverse drug reactions, one of the things you want to make sure is you get the 5 rights. There's actually a few more rights in this, but these are the most common rights. So, and again, you think, right drug, think the right patient, the right dose, the right route, the right time. You think these are pretty common sense sort of things, right? Do you think these are foolproof and they happen all the time? They happen perfect every? No. So again, when you have a sign that says like, make sure you please flush the toilet, guess what? That sign's there for a reason. Someone probably wasn't flushing the toilet. So you think things are pretty self-evident, should be pretty obvious, but there's probably someone who's done it to make sure there's an issue. Have you guys heard of the Swiss cheese model? So Swiss cheese model is something you hear about when you talk about like medication errors or errors in the hospital. And basically it means that, like, there's several steps along the way. So from the time that you decide you want to give a medication to a patient, I use medications as an example. So say you want to say, I want to give this drug to this patient. Okay. Well, what happens to that order? Okay. Well, the order gets transmitted over to the pharmacist. Okay. So you're the first check. You make the decision to give this drug. You say the dose, the route, all that good stuff. Then it goes to the pharmacist. Imagine you made an error on that drug order. So say you accidentally give, Rocephin or ceftriaxone or a drug that is in someone who's severely allergic to it. Okay, so someone has an allergy, you missed the warning or you blew past the alert that came up in the computer, we just went through. So you're the first hole, right? So you're the first person that that error has now slipped through. Okay, then it goes to the pharmacist. Now the pharmacist just blows through the thing and just says, okay, well the provider said they wanted it, must be right. So we go ahead and verify it. Now we're the second hole of the Swiss cheese. And so see, as these start to line up, you're going to find that these errors that should be pretty easy to catch, you would think, can actually make it all the way to the patient. So from the pharmacist, who's it go to? Go to the nurse. Like maybe the nurse at the bedside. So she actually goes and pulls the drug, and she asks about allergies, but she doesn't make the connection that, hey, this patient is allergic to this. And then it gets administered to the patient, and guess what? Now they have an anaphylactic reaction. Okay, so that is one of those things where you have multiple steps along the pathway. Like, yeah, the provider should have known about it, but then the pharmacist should have caught it. The nurse should have also caught it, but you'll have these holes all line up, and then you can have a medication error, right? So these are why we have so much technology in place to try to prevent errors, and this is why we talk about things like the 5 rights to make sure that we are doing right by the patient, getting the right drug to them in the right manner. Okay. So, for instance, the right drug. Okay, well, it seems like it should be pretty obvious, but looking at things like drugs with confusing brand names. If you look at different drugs, there's an XR formulation, there's an SR formulation, there's an ES formulation. You have to make sure you're getting the right one, because you can find that the dosing can be wildly different between the two. So frequently, when you say, for instance, and I talk from the hospital perspective because that's what I know, you have a patient coming into the ER. The person who does the medication reconciliation is usually the nurse, right? The nurse at the bedside. And so she's quickly, because she's got a million other things to do. These are very busy people. They have to go through and they just kind of pick a bunch of meds that sound what the patient told them. Are they actually like calling the pharmacy to make sure the dose is right? To do, when's the last time they had it filled? All this kind of, no, they don't do any of that because they don't have time. So then when they get admitted, then the provider goes through and they're like, okay, well, let's just continue all of these. The doses may be wrong, could be the wrong formulation, and then the pharmacist has to go and try to make sense of it. And if we just go ahead and verify it all, guess what? The patient may get the wrong type of drug. Other things like over-the-counter products. When you say Tylenol, what do I mean? You think it's acetaminophen. Is that the only kind of Tylenol there is? No, there's different doses of the Tylenol. There's Tylenol PM that has Benadryl in it. There's, again, these people like to use their brain names on everything, so that when you see Tylenol, you think, okay, Tylenol's a good drug, and then just grab that, right? So you have to be specific when you're talking about things like NyQuil. Like, okay, what's actually in that NyQuil? Is there Tylenol in it? Is there an antihistamine in it? Like, you have to be kind of specific when you talk about that. The other thing, being in Florida, being in Orlando, guess what? We get a lot of foreign people coming in to go see the mouse or go to Universal or wherever they want to go. And so you get a lot of foreign medications. So things like, if you have a patient who's coming from England who has, say, asthma, and they come in and they have salbutamol, like you're trying to figure out what meds they're on, they say salbutamol. That's actually albuterol, okay? But if you didn't know that, guess what's the best way to consult to try to figure out what these drugs are? Google. Google Foo is an important skill to develop as a healthcare provider. Paracetamol as well can be, in the UK, you'll see paracetamol is actually acetaminophen, right? So some of the ones you'll kind of get used to if you see these patients frequently, but very often I have patients from like South America, from Brazil, and other countries who are coming in, and they have like all these pill bottles are in Portuguese. Now, it's one thing if they speak Spanish, it's fine, because usually we have a lot of providers and nurses and things like that who are bilingual, or you may be bilingual yourself, but I mean, how many people do you know speak Portuguese? Actually, I have one. Okay, so you speak Portuguese. I have one other student who speaks Portuguese. Yeah, so there you go. So you'd be able to figure that out. But otherwise, I have to go to Google and try to do a translation and make sure I get everything correct. But otherwise, you can be. I remember I had this one doc who's Puerto Rican, and the nurse came up and they're like, "Oh, you can go talk to them. They're from Brazil." She's like, "I do not speak Portuguese." Very offended by that. But anyway, so yeah, so you have to make sure that you can find ways to translate this information to make sure that it's actually accurate.
They use the same brand name in India.
Oh, okay.
Recently took paracetamol.
Yep. Do you use salbutamol as well?
Yeah.
Yep, there you go. So maybe that has to do with your British roots or influence. Who knows? So anyway, so yes, you'll see all kinds of different things. We get patients from all over the world, and especially like at Nemours, we see them a lot because we have a lot of like Make-A-Wish kids who will come from various places. They go to Disney, they get stressed out, or they get sick, and then they come over to us. And so we have to kind of make heads and tails of these very complicated medications. And again, if they're in a different language, that just adds another layer of complexity on top of that, right? The right patient. So again, you think it should be pretty easy to give the drug to the right patient, right? Not always, right? Right now over at Nemours, we have a NICU where we have 3 different sets of twins. And we like to put them all in the same room, or we like to put individual twins into the same room because, again, it's good for the family and all of that. So we'll have baby A and baby B. We have 3 sets of baby A's and baby B's with different last names, right? So again, okay, that's complicated. The other thing is usually like with our room settings, so you'll have like 3115A and 3115B. So what do? They put baby B in bed A, and they put baby A in bed B. Like, come on, like you're just trying to make it hard for us, right? Like, so that's why we have things like barcode scanning to make sure that actually you scan the patient to make sure that it's the correct person. You scan the medication to make sure it's the right drug, and then you administer it. But what happens if the nurse just is in a hurry and she goes ahead and just gives the medication? Because I can't tell you how many phone calls I've had where they said, well, I think I may have done it wrong, and it didn't pop up until after I gave the drug when I barcode scanned. I was like, well, why didn't you barcode scan beforehand? I was in a hurry. Okay, that's how medication errors occurred there, right? So you got to make sure. I don't like to throw nursing under the bus because, again, they do a wonderful job. I come from a huge family of nurses, so they do a lot of work. But, again, that's one of those things where if you bypass the safety features, that's where you run into problems, right? Other thing, patients are moving around constantly. You say, hey, give the med to the patient 5113. 5113 could have changed over several times by the time that nurse actually gets around to giving it, right? In the ER especially, with rapid turnover, the patient who was in room 1 an hour ago might be someone totally different, right? So you got to be really careful with that. Make sure you're addressing the patient by their name, making sure you're using the right identifiers, like so that if you're using their MRN, so the medication record number, their birthday, address, all these good things. Yes, ma'am.
So there's a doctor that I work for in a nursing home, so he was doing a patient. And they had written down like the husband's name, and he was doing the wife. The husband had died like a week prior, so when they did the bill, they were like, and they had called the insurance, like, this person died. There's no way that you did the procedure on this patient. So obviously they got like in a lot of trouble. They did the really wrong patient.
There you go. Yep. So you can't really get billed for doing stuff to dead people, right? Not good. Yeah, but stuff like that, I mean, it's exceedingly common. So you may think, especially if you don't have a ton of like medical experience coming into this program, like you'll see all kinds of crazy stuff out there, and you're like, oh my gosh, like how did this actually happen? And it happened, right? Other things like the right. Oh, yes, ma'am.
Well, undoubtedly is that you might have 2 patients with the same first and last name, and then all of a sudden you start looking for it. You start asking this question. Like, looking at you like, who are you talking about? Well, you are so and so, yes. But
A different date of birth, and I have a different address. Yeah, so that's really important. Make sure you use multiple identifiers for your patients because, again, we have a large Hispanic population around Nemours, and so our ERs, you'll have like 3 or 4 Garcias and 2 Rodriguez's, and so it's really, especially with that rapid turnover, you got to make sure you're talking about the right patient. We'll have siblings that have very similar names, they're very close in age, and they're very close in weight, and you have to make sure, okay, well, did the nurse put the order on the right patient, or so again, be very careful with this stuff. As far as the right dose, make sure that you're taking into account their age, their gender, if it's appropriate, renal, hepatic function, all these things, to make sure that the dose is appropriate for that patient. That's going to be more on the provider side, and that's one of the things you may get a lot of calls from pharmacists saying, hey, is this the right dose, or based on the renal function, I think it probably should be this instead. That's a big thing you'll get a lot of calls about in a lot of cases. Other things, I mentioned the MedRec process is extremely important because, again, if an error happens at the first part of intake, when you're actually getting the medication list down, you do it wrong, that can get propagated all the way throughout that patient's stay. And then when the doc or the provider is writing for scripts for the patient on discharge, and they write it off of that bad information they got in the first place, now the patient's on a totally different dose than they were before, right? The good example of this is my wife works over at ORMC, and they had this case where they have pharmacy technicians who are trained to do medication reconciliation in the ER. They will then take that information to the pharmacist, who will verify it, and then when the patient gets admitted, the doc or provider will go ahead and reorder if whatever is appropriate. So the patient comes in and says they're on methadone. Okay, so the pharmacy tech said, okay, well, what dose of methadone are you on? They say, okay, write it down. They go over to the pharmacist, and the pharmacist says, well, that's a pretty high dose, but not unreasonable. Right? Some people can be on really high doses of methadone that would kill an elephant, but they've become tolerant to it over time. And okay, so that seems reasonable. So they said, okay, verify it. Then they go to the provider. The provider goes and orders it, and then the nurse administers the med when the patient gets up to the floor. Well, guess what happened the next morning? Come in, patient is totally sedated, needed some Narcan in order to help reverse that because guess what? Patient was lying. Patient said, hey, my methadone dose is this, and no one actually ever called the clinic or called who the provider was to actually make sure that was the correct dose. So the patient got way more methadone than what they should have gotten. Probably a good thing for the patient, he thought, but not good overall because again, they had to reverse that and then cause some medication error. So again, sometimes you have to call and like double check on this sort of thing to make sure that they're actually telling you the truth and for stuff like this, right? Not that patients are always going to lie to you, but they lie to you quite a bit. In my world, in toxicology, you know how I can tell when a patient's lying? Their lips are moving. So either people are abusing drugs and they've gotten themselves into trouble and they're in the ER, or they have they're trying to harm themselves intentionally and they'll lie to you constantly, right? And so again, you take what the patient says with a grain of salt, and then you try to verify, right? So you trust but verify is one of the biggest things you can do when dealing with some patients. But the right route, and so again, if it's a PO medication, make sure you're giving a PO. Make sure you're giving it IV if it's IV. For instance, we have some drugs that are fatal if given via the wrong route. So we have a lot of kids who are getting chemotherapy for leukemia. Sometimes they will get drugs intrathecally, and then they will also be getting drugs IV at the same time. There's one drug, vincristine, which they should only be getting IV. If you had a mix-up and accidentally put that intrathecally, that will kill the patient, right? It's one of those things where they have a lot of safety procedures in place to make sure we don't mix that up and accidentally give the vincristine intrathecally, because guess what? It's going to be a big deal. Patient will die, we'll get sued for it, and there's been numerous cases of that happening, so we want to make sure we prevent that sort of thing. Some cases may actually give drugs via routes that look wrong but are correct. So for instance, if you ever have someone who has, this is a new thing for me when I got into pediatrics initially, was that putting Docusay, which is a laxative, putting it into the ear. I'm like, that's weird. Why the heck would you do that? Well, actually, it's good for if you have impacted cerumen. You can actually have to break that up and emulsify, and then it'll help to clear out the ear a little bit better, right? So again, it's one of those things where you think that's a untraditional use of a drug, but it could be appropriate depending on the situation. Okay. Some oral products have been given intravenously previously. So in my world, we used to give Mucomyst for our Tylenol overdoses, the oral product IV, because that's all we had. So again, we had safety literature to say that, but it was an odd thing. And just know that drugs even via the wrong route can lead to things like tissue irritation, necrosis. A good example is phenytoin, the seizure medication. If I give that intramuscularly, and cause all kinds of severe tissue necrosis. Only can be given IV. Vitamin K, phytonadione. If I give that intramuscularly, can cause hematoma. So lots of issues. And again, a lot of systems are in place to make sure you don't do that. So for instance, and if I have like an electronic medical record system, I don't know what Florida Hospital uses, but we use Epic where I'm at. And basically, certain drugs, they don't have routes options to even do that, right? So if a drug should not be given IM, the IM option is not on there for that drug. But as providers, you should be knowing these things if you're using these drugs, how it's acceptable to give it and how it's not acceptable. And then right time. So this is important for certain medications. So for instance, if I give Tylenol too frequently, so I say, hey, take Tylenol every time you have pain. They're taking a gram. How much Tylenol can you take in a day? Anyone know? Not more than 4 grams for sure. So again, if they're taking every time I have pain, I'm taking Tylenol 1 gram. Well, they can have pain 6 to 8 times a day. All of a sudden now they have hepatotoxicity. So timing is important. Pain medications taken too frequently can see increased sedation. Emergency contraception failures, right? So imagine you're taking someone who has wanted to get Plan B because they had unprotected sex and they're worried about getting pregnant. Well, guess what? That only works within a certain time frame. If they take it, say, a week after, not going to work and they can get pregnant, right? So time frame can be really critical for certain drugs. Antibiotics even too infrequently, as mentioned, those levels can drop down too low and allow bacteria to grow. So again, be aware of the timing that's appropriate for each of these drugs. Okay, so going back to some definitions, we talk about bioavailability. What is that? Yeah, amount of drug that's actually getting from whatever dosage route it's going through and getting into the system essentially, right? So again, IV is what usually? What percentage? 100%, right? But oral can be very variable, right? So one of the things that you're looking at when we talk about bioequivalence is basically when you have 2 different drug products that contain the same active ingredient. They're identical in strength and dosage form, route of administration, but they're actually by 2 different manufacturers. This is important when we come into play when talking about brands versus generics, right? So again, we talked about before in drug development, how long do those brand name patents last? 20 years, right? So after 20 years, now you can have generic companies come along and say, hey, well, we want to give you the same drug but for cheaper, right? They have to show that their stuff is bioequivalent to the actual drug itself, right? Because you don't want to get a generic and it works worse than the actual brand name drug, right? You want it to be able to work at the same. And in general, that is true. Like, there's no real difference between brands and generics for 99.9% of drugs out there. You may have patients who are like, well, the brand just works better for me. That's not the case because they actually had to show to the FDA that, hey, our generic works just as well. They're the same bioavailability or bioequivalent to the actual brand name product, right? So this is the process we go through. Yes, ma'am.
So why is it that those two, like the brand drug versus the generic drug, gives so different side effects?
You usually don't see a ton of different side effects. Now, they may run into some issues where the things they can change, we'll talk about this in a minute, are sort of the inactive products, right? So you may have the brand name tablet's a blue pill when the other one, say, is a yellow triangle, or maybe a yellow capsule or something like that. So you may not see the drastic of a difference, but the inactive ingredients can change. And so maybe a person has a problem with, they have an intolerance to a dye or some of the inactive ingredients. That could be one thing. But in general, you really shouldn't see, from the drug itself, shouldn't see any changes in side effects, right? Anyway, so again, we know bioavailability is altered by the route of the drug itself. We talked about acid-base balance and how that can affect how well a drug gets absorbed. And then looking at things, we'll talk about bound versus unbound, and then first pass effect and then excretion and elimination just in a second here, right? So again, these are the things they have to show are the same between brand and generic to make sure that they can market it and say, hey, this works just as well. Because again, when you write for, say, a brand name drug, say you write for Lexapro, right, for depression for your patients, when it comes to the pharmacy, do we fill it with Lexapro? No, as part of the laws are set up so that because we want to pass the cost saving on to the patients, we will automatically sub that with the generic drug because it's going to be cheaper for the patient, right? Unless you write dispense as written, DAW on that script, we're going to fill it with a generic, right? Because again, we know they work just as well. They have to show that to the FDA. We feel reasonably sure that's going to be a good thing for the patient, right? Yes, ma'am.
Yes, I know we have some patients that did better on Synthroid than levothyroxine.
So that's at 0.1% of drugs I was mentioning. There's actually what we call a negative formulary in Florida, and in other states they have a similar thing where basically there's certain drugs where there is enough of a difference you actually don't want to automatically substitute those. And I think actually Synthroid got taken off recently in the past, like probably 5 years or so. However, for a long time you didn't want to switch those around because you could actually find differences in either bioavailability or just how well it was working. So you wouldn't want to use a generic Synthroid for the actual brand name version. So for a long time we didn't switch that one, but that's an exceedingly rare sort of circumstance. Yep. Anywho, so again, just you can refer back to this chart. Just remember the bioavailability can be wildly or drastically different depending on the route. Again, IV is always going to be 100% though. Again, if I have any kind of test questions or I'm asking about, you give this amount of drug to a patient, if I don't specify the route or I don't specify like a first pass effect or anything like that, just assume it's IV. Just assume it's 100% bioavailable, all right? I'm not going to like trick you guys or anything like that. If I'm trying to get at a question about bioavailability or first pass effect, I will put it very specifically on there, okay? Otherwise, you can just assume it's IV and 100%. Okay, and remember, what's kind of the key thing about acid base and changing the pH and the pK of these drugs? Remember the like dissolves like. So if I put an acidic drug into an acidic medium, it's going to be more easily absorbed. If I put a basic drug into a basic medium, it's going to be more easily absorbed. Right? It's going to be more likely to cross those biological membranes, which is important when we can have changes here. Again, every drug has a pK associated with it. I'm not going to belabor these points again. Don't memorize these numbers. Just know that every drug is a little bit different there. Okay, so remember that with the molecules, when they are more in a polar sort of state, when they're in that charged state, this is when they're going to see they're much more water soluble versus when they're in a more the uncharged state. This is when they're going to be more lipophilic. This is when they're going to have an easier time crossing over there, right? So again, they tend to be more lipid soluble than the uncharged sort of state there. Again, just like when you see like sodium and chloride, when they dissociate from one another, they are very polar because again, sodium is a positive, chloride's a negative. They will associate with water like this. And again, this is what makes them so polar. Typically, we want things to be more lipid soluble. It'll make them very easy to cross those membranes there. Unless you're a polar bear, in which case you're going to be very dissolvable in water. But anyway, so again, looking at the case of aspirin, remember we said aspirin, which just stands for acetyl salicylic acid. Do you think it's a weak acid or weak base? Weak acid, right? Yeah, so good. So again, when you put it into an acidic medium like the stomach, right, pH of 2, what kind of form is it going to be in? Would it be protonated or unprotonated? It'll be protonated, good, because in an acidic medium, you're going to have a lot of hydrogen ions floating around, and it's going to be charged or uncharged? Like dissolves like. So I put a weak acid into an acidic medium. It'll be protonated, but when it's in that state, it's going to be uncharged. So again, this is why the aspirin likes to get absorbed from the stomach, right? Because again, when I put it in this more protonated sort of form, because again, if I have a high concentration of protons here, it's going to drive this equation to the left, and I'm going to have a much more easily absorbable aspirin in the case of the stomach, right? On the basic side, say for instance I had pyrimethamine, which is a kind of an older school drug. This is a weak base. When I put it into a more basic medium, it's going to be in a protonated or unprotonated state. Unprotonated, right? Because again, as I get more alkalotic, you're losing the hydrogen ion. So again, I'm shifting things over into this direction over here. If I'm going more in an acidic medium, if I'm less acidic, I'm going to force it over here to the right side here, more alkalotic. And then when it's in a more alkalotic medium, is it charged or uncharged? Uncharged. Weak bases in a basic solution are going to be uncharged. They're going to be easily absorbed. Like dissolves like.
The only time it's going to be charged is if they were having acid in a week or a week.
If you put a weak acid into a basic medium,
Yeah.
it'll be charged. If I put a weak base into an acidic medium, it's going to be more charged. But remember, when a drug with, say, a pKa of 7, when it's in a pH solution of 7, what's the ratio between charged and uncharged? 50-50, right? When the pKa equals the pH, it's going to be 50-50. However, there's always going to be some fraction of it. There's always an equilibrium here. It's just a matter of how far you're shifting it from one way versus the other, right? So again, there's always going to be some amount of the drug that's going to be charged. However, the proportion is going to depend on the pH of the solution that it's in, right? So you can go back to the Henderson-Hasselbalch equation and notice it's always going to be that ratio between one to the other. It's how much is it going to be shifted in favor of one over the other, essentially. Okay. So again, just remember when it's protonated, it's combined with the proton. Weak acids tend to be protonated, and they are going to be neutral in that form, versus weak bases are going to be unprotonated. That's when they're going to be more neutral. So we kind of know that already. Just remember pH and pKa, when those are equal, it should be a 50-50 split between the two. Okay, so again, that's all this graph is trying to show here. Okay. You already talked about this already, but again, just know that again, if it's in a more protonated state, for acids, it's going to be in the uncharged state. It's going to be more protonated. For bases, they're going to be in the charged state. So you can kind of work through that and be able to, you can draw it on scratch paper. You should be able to kind of get that figured out to determine how lipid soluble or water soluble a substance might be. I'm trying to get this a little bit quick just so we can make sure you have get everything done for the test, and I can answer any questions you have before as far as right. So again, looking at excretion when you're looking at acid-base balances here. So again, imagine I have a weak base and say an acidic urine. Is it going to be in a charged state or uncharged state? It's going to be in a charged sort of state there. And so remember, when you have the renal tubules, things that are more lipid soluble, they like to be reabsorbed better, right? So again, in the case of I have a weak base in acidic urine, it's going to be in a charged state. It's going to bounce off those renal tubules essentially, be more easily eliminated. Okay. So by doing that, by decreasing the amount that can be reabsorbed, you're going to eliminate that much faster. If I have weak acids in a more alkalotic sort of medium, put it into a charged or uncharged state. In charged state, because again, it's in the opposite. That will help me to increase the elimination. So I mentioned like when I have an aspirin overdose and I want to get rid of it faster, I will give them sodium bicarb via IV to alkalinize the urine. So that way I will prevent it from being reabsorbed and get rid of it that much faster. Okay.
Medication, you want it to be neutral for it to get reabsorbed.
It depends. So in some cases, you may find that you may actually try to modify the urine pH to try to increase reabsorption of a drug, but more often than not, we're trying to make it so that you kind of eliminate it that much faster. Yeah. There's some other cases where, for instance, back in the day, because where do we get penicillin from? From mold, yeah. Some of you may have it growing in your fridge right now, depending on the situation. But back in the day, we used to not have a really good way to actually produce penicillin, so like it was very precious that we had it. Like it really kind of revolutionized medical care for these patients. And so one of the things we want to do is try to keep it in the system as long as possible. And so one of the things we knew was that penicillin actually got secreted into the renal tubules and got to be eliminated. So one of the things they did was actually give a drug called probenecid that actually blocked the transporters that would secrete that penicillin. So that way the levels would stay higher because it stuck around and you decrease the clearance essentially. So again, the drug stuck around for longer and you had to give less of it in order to get the same effect essentially. Yep. So again, that's more of a rare instance, but every once in a while you run into that. But again, you imagine something like phenobarbital, which is a weak acid. If I put it into more alkalotic urine, what's that going to do? It's going to charge it and then increase excretion, yeah, increase that elimination. Good. Okay, so let's go over some, kind of putting all those kinetic sort of parameters together. Let's look at something like propranolol. All right, propranolol is a beta blocker. Imagine I'm giving a dose, say it's 160 milligrams, 1 tab by mouth daily. Okay, so that's how we're going to be administering it here. So we'll look at this, and propranolol is a weak base. It's very lipophilic and has a pK of 9.4. So where do you think it gets absorbed better from, the stomach or the small intestine? Small intestine, right? It's going to be in a more basic sort of medium there when it gets into when it gets neutralized from all the stomach acids, and you'll find that it's very lipophilic. It tends to get absorbed very, very well. Okay, and again, this is one of those drugs that actually crosses in the CNS a lot. This is why I don't want to give it to old patients, because you typically find they'll have like nightmares and all kinds of CNS issues. But anyway, the first pass effect. So again, what is first pass? The liver tax. So again, basically what you're losing by the time the drug actually gets into the systemic circulation. So let's say approximately 25% of that propranolol undergoes first pass effect. So again, how much should be getting? Actually, I'm sorry, it undergoes 75%. So again, a lot of it gets metabolized. Only 25% reaches systemic circulation. Okay. So in this case, what would you say about the bioavailability? 25%, right? So it only has 25% bioavailability, only 25% reaches systemic circulation. So for our purposes, we give a 160 milligram dose, how much of it makes into the system? 40 milligrams, right? And this is, again, one of the big reasons why if you're looking and comparing IV doses versus oral doses, in some cases they're saying 1-to-1. Bioavailability is very good orally. In some cases you may find that the oral dose is much, much higher than the IV dose. Right, so you need to take that into account because the bioavailability could be such that you have to give more of the drug orally to get the same amount systemically as I would from an IV dose. Okay, so you can find numerous examples of that when looking at medications there. So anyway, so only 40 milligrams actually made it to the systemic circulation. So let's say that the half-life is approximately 6 hours. And so say, looking at metabolism, you imagine at, hour 0, once I have the actual drug being absorbed, say I have 40 milligrams that made it through, so it's a 25% bioavailability. At 6 hours, you expect maybe 20 milligrams to be left over, right? Because again, this undergoes first or zero order kinetics. Looking at this. This is first order kinetics, right? The majority of drugs are going to be first order. So you notice here that, again, I have 20 milligrams metabolized during that first half-life, but then after that, there's only 10. And then it's only 5, and then 2.5, right? So again, less drug is being metabolized per half-life because less drugs are around in the first place. Okay. So next thing we're going to look at is going to be the distribution. So again, approximately 90% of circulating propranolol is bound to plasma proteins. Okay, so this one specifically, alpha-1 acid-glycoprotein. This one's not important to remember. Just know that at this point is being bound to these plasma proteins. What do you think that does to the volume distribution? It's really tightly bound to all these serum proteins. Can it go to the tissue? Yeah, it's going to be held up. So that actually can cause the volume distribution to be lessened in that case because more of it's being bound up in the plasma there. So the other thing to note is that is drug bound to serum proteins? Is that active drug? Can it interact with those beta receptors to block them? It can't. So you need the free drug in order to be actually active. And so in this case, if I have 90% of it being bound, imagine that 40 milligrams that was made it into the systemic circulation, 90% is going to be bound to the proteins. Only 4%. I'm sorry, only 10% or 4 milligrams is unbound. This means only 4 milligrams of that original 160 is available at that given time to actually interact with those receptors. Okay, so again, not a lot of drug is needed to get some of these effects here. So again, which fraction is active? It's going to be the unbound version of it. Now imagine what would happen if I say were to decrease the amount of this protein circulating around. What do you think it does to that free fraction? It actually increases it. So you actually, instead of say getting 10%, maybe 20% is available. What do you think that could cause? Maybe increased therapeutic effect, maybe toxicities, maybe see bradycardia as opposed to just maybe lowering the blood pressure, what you're looking for. So again, you can see that by changing those proteins, you can change the free fraction. You can change how much of the drug is actually active in the first place. And pretty dramatic. Another good example is phenytoin. I talked about for seizures. If someone has low albumin, they tend to have a much higher free fraction. So even though the level in the serum looks good, they have such a high free fraction that actually causes a lot of toxicity. And we'll talk more about some examples of that later on. Okay, so let's look at, let's say we have a 70 kilogram male. Let's say we administer a dose of 160 milligrams, and we know that basically 25% of that made it through. Now we have 40 milligrams in the system here. Let's say we measured that concentration in the plasma, and let's say it's 0.14 milligrams per liter. Now the question is, can we figure out this patient's volume of distribution? And so this is the equation I want you to at least have a good understanding of. We've kind of brushed over this briefly before, but basically C0, which is going to be what? So our concentration, our initial concentration of the drug is going to be equal to the dose that we administer divided by the volume of distribution. Okay. And if I give you any math problems on the test, they're going to be very easy round numbers that you can do with scratch paper. You won't need a calculator for this. Okay. Again, the stuff we do here will be more difficult, but as long as you can do basic division, multiplication by tens and things like that, you should be okay. Right? I'm not going to expect you to do any like long division calculus or anything like that on the test. Okay. So again, when you're looking at this equation, C0 equals dose over VD, which is good to remember that. What do you think changes in dose does to my C0? So if I increase the dose, increases C0, right? Does that make sense, right? If I increase the volume distribution, decreases the concentration, right? That makes sense because more of it's out in the tissue. So in this case here, if I rearrange it and I want to figure out what this patient's volume distribution is, I can rearrange it to be basically VD equals dose over C0, right? So again, just basic algebra at that point, just kind of rearranging the equation there. So what I can do is I can look at the volume distribution, which is typically measured in liters, and so I'm going to take the amount of drug in the body divided by the plasma concentration in this case. So I know that the dose is going to be 40 milligrams, so that's what made it into the systemic circulation, and I know it's going to be divided by that 0.14. So if you were to do that, calculate that out, basically you get a value of 286 liters. Make sense how I got there? Now again, remember that whenever you're comparing volume distribution, say between patients or between drugs, you typically want to take the patient's weight out of the equation essentially, right? So in this case, what I can do is take that 286 liters and divide it by 70 kilograms, which is what the patient weighs, and get a value of 4 liters per kilogram. And if you remember, when we're talking about volume distribution, what do we say was the cutoff point between high and low volume distribution? 1. Yeah, so remember, anything less than 1 liter per kilogram is considered to be a low volume distribution, likes to be in that serum. Anything greater than 1 tends to have a high volume distribution. So even though propranolol likes to be highly bound to the serum proteins, it does like to partition out of the tissues very much because it is so lipophilic. So that kind of makes sense based off of that it would have a high volume distribution like this. Okay, so it kind of makes sense how we got the volume distribution for that particular patient.
So on the previous slide, when you say dose, that's specifically like the bioavailability.
Yeah, in this case, so we said only 25% made it through. Again, if I don't specify that on a question, just assume it's IV, it's 100% bioavailability. I will very clearly spell that out for you. I try not to be that mean, at least on my testing. Okay, so let's say we want to figure something else out. Let's say we have a 50 kilogram female, and again, I can take that 4 liters per kilo and I can apply that to other patients, right? So again, assuming that's a normal, healthy individual, I can apply it to other people potentially. So let's say if I have a 50 kilogram female, I'm administering a dose of 120 milligrams. We know the volume distribution is approximately 4 liters per kilo. What concentration would I expect to see in that patient? And then again, this is something we do pretty frequently to try to figure out, okay, well, what is likely to be the concentration they're going to achieve? Is this going to be high enough to cause therapeutic effects and not too high to cause toxicity? Okay, so basically go back to our equation here. We have our C0, we have our dose and our volume distribution. So what's our volume distribution going to be in this case? 4? Well, is it just 4 or is it? Now you want to apply it to this specific patient because we want to estimate what their individual concentration is going to be. So I take that 4 liters per kilo, times it by 50, I get 200 liters, right? And the next slide has all this on. So again, I'm going to see that 4 kilograms per liter times 50 kilograms is going to basically cancel out the kilograms. I'm just going to have that 200 liters there. And then the dose I administered, why is it 30? Because only 25% bioavailability, right? So that 120 that I gave, only basically 25% made it through. So I'm going to put my dose as 30 here. So again, 30 divided by 200 equals 0.15. And so what do we see on the last concentration for that previous patient? What was their concentration? 0.14, right? So you can see I had to give 160 milligrams to that larger patient to get roughly the same concentration as I did for this 50 kilogram patient, right? The 30 is going to be based off of the 25% bioavailability. So if I gave a 120 milligram dose orally, only 25% of that made it through. Yeah. Everyone with me so far? Again, if I give you any math on the test, it'll be very straightforward. But I want you to know that relationship C0 equals dose over VD. And that way, if I have 2 of those values, I can solve for the third one always, right?
Where was the 25% bioavailability?
So because it's propranolol, again, that's going to be just applied to that drug across the board. That's something you could look up. So again, it's going to be specific to every drug. You know, maybe for your individual drugs in the homework assignment, you look up to see what's the bioavailability when given orally. And it can be 100%, it could be 0%. In this case, it's 25 for propranolol, right? Okay, let's say we have a 100 kilogram male. The concentration in the plasma is 0.05, and we know again the volume distribution is 4 liters per kilogram. Well, what if we wanted to figure out what dose do we think this patient actually took? Because again, the concentration looks kind of low, lower than what we saw in the previous 2. What dose do we think this patient actually took here, right? So again, now we're solving for dose. So C0 equals dose over VD. I can just go ahead and change this out. So now I see that dose equals C0 times my volume distribution, right? So basically what I can do is I can take that 0.05, which I know is my concentration. I'm going to multiply it by that patient's volume distribution, which is 4 liters per kilo times 100 kilograms. So again, their volume distribution is what? 400, right? So again, 4 times 100 makes sense, 400. And then so I'm going to take that 0.05 and multiply it by 400. That value that I get from that is going to be 20 milligrams. And remember, 25% bioavailability. So that 20 milligrams is really probably what orally? 80 milligrams, right? So again, if I can assume that 75% of that was metabolized, I add that to that 20 milligrams, and now I have 80 milligrams. So I could say that 100 kilogram patient probably took 80 milligrams of propranolol in order to get that concentration. Okay. Some cases we'll do that. This one's a little bit more rare in that circumstance, but sometimes I'll get concentrations and try to determine, okay, well, you know, if a patient overdosed on this stuff, how much would they have taken in order to get that actual amount? Does that make sense based off of what they were had available to them, et cetera? You know, so we'll do it occasionally. Okay. So again, those are the type of kind of questions I may ask on a test. Again, very basic math you'll be doing here, so don't stress out too much about it. Again, as long as you keep that relationship in mind, C0 equals dose over VD. Okay. All right, so when you go back to bioequivalence, again, when you're looking at you know, these different manufacturers, you need to make sure they show bioequivalence. They need to be able to show the same concentrations that are achieved in the patient, despite them having, you know, maybe different colors or different shapes or different inactive ingredients. So you imagine bupropion XL, this is a common antidepressant you're going to run into versus, say, you know, two different brand names here. You would see that they need to have very similar concentrations achieved when administered to a patient, and it should have very similar elimination as well. Right? So everything should be roughly within certain parameters to say that they're bioequivalent. So that way I know that if I were to give this one drug to a patient and then substitute it with one of these other versions, that it would be totally fine. It should have no issues with that whatsoever. Okay. Who do you think determines if things are bioequivalent or not? FDA, right? So again, these are things that have already been done before you ever prescribe a drug. They've already been figured out whenever you say, hey, is there a generic available? To get that approved, they have to show all this bioequivalence, okay? So again, there's a couple of different varieties here. You can have a pharmaceutical equivalent. These are going to be things that have the same active ingredient, same dosage form, same route, same strength, all of that. The only things that are going to be changing are going to be maybe the shape of the drug, maybe the scoring of it. And again, scoring is what? If it has like a mark in the middle of it, so you can pop it in half or something like that, that's scoring. You know, a release mechanism, packaging, excipients, all those things. Excipients are just kind of the other stuff that goes into a pill besides just the actual active drug. So that would be pharmaceutical equivalent. Pharmaceutical alternatives are typically going to be things that are going to have different salt forms. These may not be interchangeable depending on the case it may be. So for instance, tetracycline is a type of antibiotic. There's a tetracycline hydrochloride, and then there's like a phosphate complex. One may not be equivalent for the other, and so this is not something that we would be able to switch out on the pharmacy side, right? You'd have to specify which one you wanted, and we'd have to fill it with that essentially. And then there are going to be therapeutic equivalents. These are going to be things that are already pharmaceutical equivalents, but again, they're going to be shown to have the same clinical effect and safety. So this is what the actual FDA is looking for to make sure that we can give these interchangeably with one another. So they have to prove that they're safe and effective, show that they're pharmaceutical equivalents, right? So they have the same drug and same dosage form and all that. They have to have identical amounts, and then consider to be bioequivalent. So they have to, drug companies show the studies to say, hey, here's the brand name drug, here's our drug, here's how they compare, and they overlap very well. We think this is going to be okay for use as a generic, and the FDA either says yay or nay, right? Okay, so that's why we can sub out generics. Again, some people will say, well, the brand name just works better for me. Again, there may be some merit to that. A lot of times, though, placebo effect is very, very powerful. Some people just feel the brand name works better for them, and maybe it does. But again, generally, you can fill it with generic, and it's totally fine.
Does bioavailability affect steady state?
So that's a good question. So for instance, if I were to have, say, bioavailability change, so for instance, if I were to say, you know, have an issue to where maybe I'm not absorbing as much drug as I did before, maybe I had like say there's a CYP interaction where I induced a CYP enzyme and I was metabolizing more of that drug, the bioavailability would go down. What do you think it does to your steady state level? So if I'm metabolizing more of that drug, it should decrease it, right? So again, if I have a drug that's less bioavailable, I would expect that steady state level to go down. It's almost like decreasing your dose, right? On the other hand, say for instance, I were to say go from say an oral administration, right? So I was giving a tablet orally, and then I wanted to switch them over to IV, but I did not take into account the bioavailability, and so maybe I was going from say 25% bioavailability to 100%. What do you think the steady state level will do at that point? It will go pretty dramatically, right? So that's why you have to make sure you take into account those changes there. I had a case like that just recently where someone was on levothyroxine there for hypothyroidism, and then they were NPO, so they couldn't take anything orally, so the provider wanted to switch them over to IV. They wrote for the same dose, PO and IV, which is not appropriate because, again, it would have led to having much higher bioavailability IV. The level would have been too high for them. It could have developed hyperthyroidism, right? So it's one of those things where we had to actually look at the reference and be like, okay, well, we actually only want to change it by this percentage, so let's go ahead and do, you know, I think we did like half a dose or whatever compared to what the oral dose was, and we're able to get that, right? So that way the steady state level should not change whatsoever, ideally, right? Any other questions I can answer for you? Okay, so this will be the end of the material for the second test, so it's only going to be over section 3 and 4, I believe, right? So going to go by the syllabus there. The final, though, is going to be over everything, right? So again, that's why it's going to be longer. It's going to be cumulative. This is only going to be, again, 25 questions. We'll kind of do it similar to what we did last week or 2 weeks ago, whatever it was. And then we'll have the homework assignment due next week as well. It'll be due the same day as the test. And then I think that'll be it for a little bit. Any other questions or anything I can answer for you? If you have any questions, please email me. Sooner than later is always preferred. All right, I'll see you guys next time.